meeting. I'm happy to welcome you to today's session. So we'll be focusing today on the topic of estimating the burden of COVID-19 in India. And we have two excellent speakers today, Rukmini and Murad. My colleague, Professor Gautam Menon, will be introducing the speakers and also telling you slightly about why we thought of organizing this symposium. So before that, I request Professor Ramanujam to introduce ISRC to those of you who are not aware of its activities. And just a general request to all of you. Please mute your mic and only let the speakers be unmuted while they speak. And if you have any questions, please put it on the chat box. We will have an extensive question answer session at the end of the presentations. So Jam, over to you.
Thank you. Welcome everyone. The Indian Scientists' Response to COVID-19 was formed in March 2020 when the crisis was just beginning. This is a voluntary group consisting of scientists, engineers, students, some artists and designers who came together at the time of this crisis to provide whatever response we could give and also act as some scientific interpreters and translators for all the information coming in for the general public. At the site insidecove.in, you will see that we have tried to provide resources for the public, for scientists and professionals that we could gather. And also several models that our modeling team has been involved in. And there have been extensive discussions that we have taken up with the public. Request you to take a look and be part of it and contribute to this effort. Thank you very much. And back to Gautam to introduce the speakers.
Yeah, thank you, Jam. And so to start out, sort of regarding the topic of today's discussion, which is what is the cost or the burden of COVID-19 in India? There's little doubt that the second wave of COVID-19, which started around the 15th of February of this year, hit India very hard. Now that we're on the downswing of that wave, it's worthwhile trying to examine what are the lessons that we've learned from this and what are the lessons that we could take from this going forward. And one very important question in this regard is what is the cost of COVID-19? We don't know yet. There are large uncertainties regarding the geographic spread of the disease, the success or not of any attempt that we've made at mitigating it, and the extent of undercounting of both cases and deaths. An example that we don't remember clearly enough is the example of the Spanish flu, where roughly 1 in about 10 or 15 Indians died. There's little historical record of this, there's little memory of this, little collective memory of this, and there's Chinmay Tumbe, the economic historian, has written a history of this in the context of epidemics over the last 100 years. But it's true that, like Spanish flu, it would be unfortunate if we forgot the history, the lessons of history going forward, especially this very, very critical time that this country has been through. As has been said, when we plan for the last epidemic, and we don't do enough to plan for the next one. And certainly one aspect of that planning ought to be our understanding of the importance of data, the relevance of data towards anything that we might do to mitigate what we might see in the future. So we have two outstanding panelists to discuss this question of data, the importance of data and what we know about it currently. One is Rukmini S., a data journalist based in Chennai. And the second is Murad Banerjee, a mathematician working at Middlesex University. So let me start by introducing Rukmini. I'll introduce both of them one after the other. I'll first start with Rukmini, then ask Rukmini to go on and speak, and then we'll move to Murad first. So Rukmini is an independent journalist, data journalist based in Chennai. She was the first data editor of The Hindu and the Huffington Post, India. She writes on socioeconomic and political issues, focusing on inequality, gender, and caste. She lives in Chennai, where the Institute of Mathematical Sciences is. So Rukmini, before you start, just one sort of general question. You've worked in a bunch of different areas that relate to issues surrounding gender, caste, accessibility, inequality, etc. What has moving towards thinking about COVID over the last year or so, what has that meant in terms of sort of rethinking the nature of data that's available for COVID versus all of these others? Maybe we could just start with that and then have you go ahead and present. Rukmini, go ahead.
I suppose what it's done in a way is is made me think both of the legacy and institutional issues with Indian data, as well as the new issues that come up with, in this case, the pandemic, or in other things that we talk about. And sometimes talking about both legacy issues and new seems as if you're sort of playing a both sidesism game, but it really is the case that, and I'll talk about this in the presentation, is that a lot of my thinking, and let me not speak for everyone, but I'd say some public health professionals and journalists thinking coming in as well was partly informed by what we knew already about the state of both disease, mortality, and Indian data, and it did help. But there's also things, we've come up against the limits of it quite fast, and we're having to think not only of new sources of data, but also of the new democratic pressures that we need to be putting on. I'll talk about that a little when we come to the CRS data as well.
Okay, do you want to go ahead and share and start? So both the speakers will speak for about 10 to 20 minutes, and then we will move to Murad after Rukmini finishes. And after that, we will open up for question and answers, which Pinaki will. Go ahead.
Okay, so I want to start by saying that if journalism is accused of, clickbait, which is to oversell something right in the beginning, what I'm going to do is undersell right in the beginning by starting by saying that I don't know and I cannot put a number on I don't have an estimate for COVID mortality in India. But what I'd like to do is to be able to walk you through sort of the waves of thinking that have gone on around COVID mortality in India and how that's changed. So I'm just going to run quickly through a presentation just as sort of thinking points to go ahead. Sorry, I always seem to run into this. Okay. So what I would prefer to do really is to talk about the political economy of mortality data and how the thinking around it has changed as we've gone through both last year and this year. And I think this speaks a bit to Gautam's point as well about learning from what's happened in the past, because there was a very significant shift in the way we thought about numbers that we've seen now. So there's four things that I want to talk about. One is the knowledge that we came into the pandemic with, then the sort of thinking that happened at the beginning and during the first wave. Then we were at sort of this moment in September and October last year, which is that the first wave had receded and we were beginning to rethink some of the things that we'd gone in thinking. And then when the second wave hit, we've had to change our thinking substantially on a number of things. So there's three big things that I came into the pandemic, for example, thinking about and knowing about the way data works in India. One is what we know about the burden of disease in India. So it was important to know the status of epidemiological transitions in different states and how significant those differences were broadly among the northern and southern states. It was important to think not just in terms of non-communicable diseases and comorbidities, but also in terms of the overall sort of communicable disease environment. So this is a sort of broad estimate from the global burden of disease, which I know, there's a lot to criticize about the IHME's modeling and estimates, but this is sort of the broad estimate of deaths from disease in India for 2019, but that's again a projection from the last time the GBD had this data. But I think it was really important to know right from the beginning that India's official counts, not just of, the undercounting of COVID, comes from a long history of undercounting other communicable diseases as well. We know that it's happened with malaria, for diarrhea, it's a different set of variables, but we know that this has happened with dengue and typhoid, for example. The other issue that we went into the pandemic knowing about is the state of death registration in India. Now there's been quite a substantial improvement from 2018 to 2019, and there's new data that's just come out for 2019. But let me just talk about the 2018 data for now, which is that we have on average India had 86% death registration, which is 86% estimated register. And we can see the big issue with states at the bottom end. There's Bihar with 35% over there, and then there's a bunch of states with 100% registration. So it's important to think differently about these sets of states. There's also the issue, sorry about that graph, there's also the issue of medical certification of deaths, which is in establishing cause. And I think this again is something that that's important because we're going to talk about it in the end, but we all know that this is an important issue about knowing about excess mortality and then thinking about how much of that can be potentially ascribed to COVID. I know Murad is better placed to talk about it. I just want to lay the background of the difficulty in establishing cause of death. So that was the sort of, I feel, legacy institutional knowledge about disease that we came into the disease and disease data that we came into the pandemic with. And then this is sort of how I feel like the sort of oral history of thinking around these numbers, that's how it went through the first week. So the first thing, there was a point where, at least in the beginning, when models were the only numbers, if you think of the lockdown months and just before the lockdown, the idea we were given is that why it was important to take this really seriously is because this is what models were showing, this exponential growth and this CFR, case fatality rate, which seemed like a sort of established number that X% of people who contracted COVID were going to die of it. There was uncertainty. How well it was communicated is debatable. So we did think of CFR as a sort of fixed number at that point. And which led us immediately to think about whether India's numbers seem surprisingly low. So this was towards the end of the first wave, a comparison of CFRs, which is reported fatalities as a proportion of reported cases. And India was among the lower countries, which led to some discussion about whether there was something exceptional going on in India. And I'll come back to that point of exceptionalism again. Then among the chipping away at the certainty began, I think, with a clear understanding that what was being defined as a COVID death was at odds with what the WHO and the ICMR's guidelines for India was. What we did quite early on is that India was erring on the stringent side of definitions rather than the lenient side, which is what the WHO encouraged. So we were only getting confirmed deaths and not suspected deaths. We can talk about this more in the questions. I think what also immediately began to be known is that not all deaths were being counted. You knew this immediately anecdotally from friends and family, from news reporting. What also was established institutionally in the first wave was the state level audit committees, which were supposed to review death certificates that were coming to them and then establish which of these were COVID deaths or not. These were not open to the public. They did not give data under the RTI. And so that barrier and that level of opacity began to be clear right from then. What also happened during the first wave is the first state revisions, notably in Maharashtra, but also in Tamil Nadu, where states, after this audit, sort of revised their numbers, adjusted for backlogs. We've seen more of that now in the second wave. In addition to this sort of heterogeneity that we were seeing apparently across the country, we were also beginning to see what's within Indian states as well. And it was inexplicable, an inexplicable heterogeneity in terms of official reported deaths. So I'd say by the end of the first wave, there were some of these questions that were coming up. That was India exceptional in some way, or should the question have been, why does India not seem to be following the same epidemiological and mathematical norms that the rest of the world is following? Is it not exceptional? And is the problem then with our numbers? And I think that question started being asked then. We also started wondering what the issue was about this great disparity between states. And that's when the question of, are numbers being counted correctly? Is it fair to compare states with vastly different state capacities, which might not be doing equally good jobs of counting all deaths? Is that an issue that started to come up? I think what also happened is that it became quite apparent that there wasn't a direct cause and effect relationship always at all times in terms of, say, potential super spreader events like some elections or some festivals which weren't immediately leading to big outbreaks in states like Bihar. That was another question that was not clear at the time. And another thing that became quite apparent is that we weren't, with the absence of age-wise, gender disaggregated, income disaggregated data, we weren't sure what it was we were missing. I know there were some early papers that were done, estimating infection fatality rates by age, and then asking if there was something strange going on in some age segments. And I think that was important to do at the time, and I wrote about it as well. But I think some of it has just exposed gaps in knowledge, and some of this came to be clearer later on. So a number of things happened between the first two waves. One, of course, was a big increase in data available from sero surveys. I think even the thinking around sero surveys went through a couple of waves for me, certainly. At one point, it seemed like these were clear numbers of clear immunity or clear sort of seroprevalence before we started thinking enough about variants, and that of course has turned things on its head. So what sero surveys did to our understanding of mortality and calculations of IFR, that too went through a sort of transition over time. So the sheer sort of horrifying way in which the second wave hit made sure that it's no longer deniable that there were mass casualties which were not being captured by official numbers. It was very physically and visually visible everywhere. I think there was also substantial, improvement in reporting by the media, where it was, especially within smaller cities, where it is immediately apparent to a journalist that what she is seeing in a hospital and in the crematoria burial grounds is not being reflected in the data that's being put out for her city for that day or her village. There was also an increasing understanding of the Delta variant in particular, and an understanding that this would affect what we knew about IFRs, and that the sort of maybe a linear relationship that we had expected was not going to work the same way. And the last thing that happened, I would say, was in the last few weeks, there's been a surfeit of excess mortality data. So what this has meant essentially is data from the civil registration systems of various states, which has shown deaths from all causes and allowed some calculations, crude calculations of excess mortality compared to past years. So I'll just quickly run through a few of what we've seen. This is what we saw in Chennai city, for instance. And we can talk a little bit about interstate and intercity differences, because I think those will come to be important. Chennai's, the difference between the rise in excess mortality became quite clear in 2020, beginning in 2020, and 2021 trends are still to be clearly established, because Chennai's surge came a little later as well. And I would not expect us to have good data for May by early June. I would wait till the end of June for that. Then from Madhya Pradesh, there was this, the sort of bar chart that you never want to see for May, where all-cause mortality shot up to 5 times of the previous average. And this is, the chart on the right is a sort of crude one, and I know Murad will be able to bring much more nuance to this conversation about how to think about excess mortality when compared to COVID mortality. And as I said at the beginning, this is the part that I don't have the answer to. I can lay these two bars against each other, but I can't yet, I can't say what they mean for each other, and I'll defer to Murad on this. This Andhra Pradesh showed quite a similar graph for May. And we've also got some limited data from Karnataka, Kerala, and Tamil Nadu, which show much more modest differences between the excess mortality and the official COVID count for that time. So I'm going to just stop, and I'll be glad to take questions on this later. But when we talk about the questions that we need to be asking now before the next wave, one is of course this, and I look forward to hearing from Murad about this, which is that I anticipate getting more excess mortality as more reporters dig this up from other states and cities. I would like to understand how to think about what share of this can be ascribed to COVID. Also because I don't want to minimize the horrific strain that was placed on the health infrastructure across the country, particularly in smaller towns and rural areas. And every death, every excess death is one too many. So I don't want to minimize deaths from those things as well. We need to still figure out if there was a rise in infant mortality, which often happens in emergency periods. All of that needs to be figured out. Then in light of what we know about the Delta variant in particular, we need to start thinking about how to recalibrate our thinking about infection fatality rate. And I know people are working on this already. And then we need to think about what we need to do to come closer to the answers. Is there a way to recalibrate sero surveys, or are there pure mortality surveys that need to be undertaken? Those are some of the questions that I think about when I think of questions to ask before the next wave hits. Thanks, Gautam.
Thanks, Rukmini. And so let me now introduce Murad. So Murad Banerjee is a senior lecturer in mathematics at Middlesex University. He's been tracking India's COVID-19 epidemic using both modeling and data analysis. He comes from an applied mathematics background. He's worked in dynamical systems, and in particular, dynamical systems with some sort of network structure. So the problems that he's worked on include chemical reaction networks, as well as a number of biomedical areas, including mitochondrial oxygen consumption, all terms dear to me as well. Do go ahead. Let me just ask you one question, as I did for Rukmini as well, just to start things off. You've moved from an area that is traditionally fairly hardcore applied mathematics into thinking about much more diffuse questions, the errors that could arise in mortality calculations, etc. So, I mean, out of interest, just because also the Institute of Mathematical Sciences has a lot of mathematics students who are interested in finding out other things that they can do with the mathematics training. So I'm just wondering what your transition was between what you were trained as and the topics that you're thinking about now.
Well, thank you first.
You're muted, Murad, sorry. No, still muted.
I'm now unmuted, I think. So thank you for inviting me, Gautam. And so to answer your question, the transition was a really practical one. It was a transition which was based on actually being in Mumbai at the time that the epidemic was kicking off and watching the data day to day, watching cases and eventually deaths start to grow and trying to come to some kind of understanding of what was going on. And so I say being in Mumbai, so obviously there was kind of local focus there, but obviously I was looking around at what's going on in other parts of India and then what's going on more widely. And a lot of the focus, a lot of the questions were really about, is this disease, is this epidemic going to play out in the same way in different parts of the world, or is it going to play out differently? So that broad question, because I'm a mathematician, I suppose I tried to answer many questions through the lens of mathematics. And that's why I started to do some modeling and started to look at COVID, really. So I will continue. Through that process, the first thing I want to say is that Rukmini's excellent talk in a way laid a lot of the background for what I want to say. And one of the first points that Rukmini made was that when you're thinking about a new pandemic, it's new in lots of different ways for all of us, you come in with some preconceptions and you come in with some kind of framework. And I think it's really essential to acknowledge that you do come in with a framework of understanding that you're going to use to try to get a handle on what you see in the pandemic. And for me, I didn't have much knowledge about epidemiology in India, about how other diseases, transmissible or not, play out in India, and about undercounting of deaths. Instead, I was coming in with some basic knowledge of epidemiology, and I was actually looking at data from a lot of parts of the world. And so I was kind of starting to spot differences, and I was trying to understand what were these differences in space and then also in time, because if you track the data in a place over some time, you start to see some changes and you start to ask the question of why these changes are happening. Are they changes connected with the epidemic, or are they changes connected with the way data is being recorded, is it actually an underlying genuine change or not? So I kind of start at that point, really, because I was looking at Mumbai's data, and one of the things which started to become rather clear in Mumbai's data was that around the middle of April, you were seeing a change, which was clearly, from my very basic models that I was running, quite an important change. The models were predicting, based on cases, based on whatever understanding we had about detection of infections, they were predicting more deaths than were actually being seen in the city. So deaths were starting to go, in inverted commas, missing in the city. And actually, that was the first question that I really explored in any depth with modeling or with anything else. So in a sense, I came at it at this whole kind of COVID pandemic from the point of view of thinking about death undercounting. I'm not saying I came straight away to the conclusion that this was about undercounting of deaths. There were several different hypotheses about why the city was seeing fewer deaths than expected based on its early data. And I think the actual eventual answer for what was happening in the city was a mixture of things. I think that the city was seeing undercounting of deaths, which was growing at the time. We know this because eventually this was resolved, or partly at least resolved. There was a major reconciliation and a lot of deaths were added back into the city's toll. At the same time, I think the disease was starting to spread in the slums. And as disease spread in the slums, which are a younger population, you expected, at least to some extent, that fatality rates would go down. So you would expect to see fewer deaths than expected based on the number of cases you were seeing. And how those different effects added up is still not completely transparent, but I think we were seeing a mixture of those two effects. So through this process of trying to come to understand what was going on in one city, I think it led one to a framework of some kind. And this framework was, very broadly speaking, well, we need to understand two things. We need to understand what's going on in terms of the spread of infection. How wide is it? Is it even? Is it changing, say, in a city like Mumbai, between slums and non-slums, but in the wider context between urban and rural areas? So can we kind of track how the city is moving in different geographical regions? And then the second question is, can we track what's actually going on with mortality? Can we track what fatalities are doing? And at that stage, of course, we were really kind of limited in terms of understanding fatalities. We were really limited to whatever official COVID-19 fatality data was out there. That was really the source of knowledge. Although it was becoming increasingly clear to many people that, in fact, official COVID-19 fatality data was limited. I'm certainly not the only person who, by the middle of last year, let's say June, July, was kind of quite skeptical about some of the numbers that were coming out. And I think, since we're talking about frameworks, I think having that kind of maybe growing skepticism, a framework of belief that I don't think something exceptional fundamentally was going on in India. That was kind of, if you like, a belief, not a kind of very firmly held one, but I didn't feel that something exceptional was likely to be going on with the epidemic. I felt that it was more likely that exceptional things were going on with the data and the data recording. I think that kind of led me to explore a number of questions. So I started to look at serosurvey data quite carefully. A lot of serosurvey data has come through over the course of the pandemic. Not a lot of it has necessarily made the headlines. Not a lot of it has necessarily been reported in a great lot of detail. So sometimes you're just left with a few figures from a small piece of one article which say that such and such seroprevalence was found. But anyway, it was a very important and valuable stream of data, however messy it was. So I started to look at that. And then you started to see some really striking things. So, for example, if you compared what was going on in states like Bihar and Chhattisgarh, which are not geographically a million miles away, which are not very different demographically, not very different in terms of levels of poverty, you saw very different things going on, for example, in the number of fatalities you were seeing relative to the seroprevalence that you were seeing. So I mentioned those two states partly just because they've both released some serosurvey data. So there was actually data about how much disease had spread. And then there was data, obviously, about how many official COVID deaths had occurred. And you were seeing really different patterns in these two states. You were seeing apparently many, many more deaths occurring in Chhattisgarh than you were seeing in Bihar. You were seeing some rural districts of Bihar, which had very widespread already. This is quite early, by I think August of last year. They've seen very widespread, as in over 20% seroprevalence was being reported, and yet had recorded almost no deaths. And I mean that literally. I mean deaths in the single figures. And this is in a district, for example, of 5 million people, 20% plus spread, according to the serosurvey, and almost no deaths. And I think the first question you have to ask at that point is, what's our kind of conceptual framework when you see such a big disparity between what you expect based on data that you're seeing everywhere else in the world, but also based on data that you're seeing from other parts of India. And then, you see this data coming from one particular state. What's your framework for that? And for me, the framework would be, I suspect that we're seeing very large-scale undercounting. And then gradually, the way this story evolved through the kind of latter part of the first wave, as cases and official deaths started to wind down, was that we saw little bits and pieces of excess of mortality data getting released. Sometimes the newspapers would obtain mortality data for one city for a few months. Sometimes it would be just one snapshot of what mortality had been in 2020 versus previous years. And increasingly, those little bits and pieces of mortality data that were coming out seemed to bear out the story that recorded deaths were actually often a small fraction of the true deaths. The caveat being that in this case, the mortality data was generally coming out from urban areas, from areas perhaps where we expect disease and death surveillance to be better. And so, in fact, possibly underestimated the scale of the problem that we might be seeing in rural areas. Added to this kind of whole understanding was that I think the work of journalists, including Rukmini and several other journalists who were following the events on the ground, was telling us that these missing deaths that might be occurring, so this kind of missing part of the story, actually, it shouldn't surprise us too much. I mean, if you actually look at what happens on the ground, look at the process by which potential COVID death does or doesn't get recorded, there are so many barriers to that death being recorded as a COVID death. First of all, people generally have to die in hospital. And we know that in rural areas, a lot of people are going to be dying at home. The death most likely has to occur after a positive COVID test. But sometimes the deceased is never tested, or sometimes they're tested, but it's at the wrong point in the disease cycle and they test negative. Regardless of all the other considerations, that death is very unlikely to be recorded as a COVID death. So you need to die in a hospital, you need to die after a positive test, and then layered on top of that, you might have these death audit committees that Rukmini was talking about, who will then go examining deaths and deciding whether these were genuine COVID-19 deaths or not, and in some cases deciding that on the basis of very spurious reasoning, which doesn't really match up, which doesn't align with what the ICMR and the WHO advise on that process. So you had these many different layers at which somebody who died of COVID might end up being left out of official fatality figures. And as that became clearer and clearer, it became in some ways less and less surprising that you might be seeing very major undercounting taking place. But in a way, although we kind of suspected that more and more, many people, there wasn't really a lot of evidence. And I think what's happened in the light of the second wave and in the light of what's been happening very recently with excess mortality data coming out is that we now have a much clearer understanding. I will try to explain, what my understanding is of this data that's coming out of the second wave, perhaps more through the questions and answers. But I'll just kind of give you a very brief summary of what I think are the key points. One of the three key points is that mortality has been very high during this wave. We're seeing this very consistently from all the places where we're seeing mortality being released. What varies a lot is the actual level of undercounting that we're seeing. So how does the mortality, excess mortality data match up with official COVID mortality? That can vary a lot between places. But what we're seeing quite consistently is that the overall mortality is very high. And I can try to quantify what exactly that means, perhaps in questions and answers. I think we're seeing that mortality is higher during this wave than it was during the first wave, because we're also getting some all-cause mortality data from 2020. So the all-cause mortality data from 2020 for me is very valuable because it's the first chance to really try to see whether those feelings of what was going on last year and during the first wave actually are borne out. And I think they are on the whole borne out. I think the mortality data coming from last year is telling us that, yes, you did have massive undercounting, very variable between different states, but still on a very high scale overall. But I do feel that mortality has increased during this wave. So you're seeing like absolutely shocking figures, really, like in 1 month or 2 months, you're seeing something like 2 in 1,000 excess deaths. And I mean, if people kind of follow mortality data, they'll realize that's really quite a shocking figure, 0.2% excess mortality over the course of a couple of months that we're seeing in a few states, in fact. So this wave has evolved very, very fast. It's gone very, very deep. Infection has gone deep into rural areas. We see that again and again. We looked at lots of rural reports recently, and you see that it kind of rages through villages very quickly, and it causes very high mortality in the villages as well. There's nothing protective about living in an Indian village. On the contrary, if anything, it's the other way around. Your chances of having access to oxygen, of having access to hospital care are reduced. So I think one of the questions which people will want to ask about this wave when all is said and done is how much of the mortality, once we get a handle on just the scale of it, how much of it was avoidable? And this is a crucial question because we are seeing that a lot of deaths are occurring which are quite possibly avoidable. They might not be people who, with access to decent hospital care, with access to oxygen, would have died given the infection. We might be seeing an increase in mortality because of more deadly, more lethal variants which are in circulation. That's also important to bear in mind. So we might be seeing an increase in mortality because disease is spreading in more vulnerable populations. So where there are more elderly people, for example. So we know that in the first wave, disease hit the urban slums very, very hard, but was relatively less rampant in urban non-slum areas and in rural areas. We know that in this wave, it's hit actually across the board, but has particularly run through rural areas, which suffer from multiple deprivations, but it also might include many people who are vulnerable in various different ways. So I think the question of what explains this very high mortality will be an important one to try to understand going forward. So I think I'll just kind of stop there because I'm happy to talk detail in the questions, but that was just the kind of general overview that I wanted to give of my understanding of how this has played out so far. Gautam.
Thanks, Murad and Rukmini, for the nice presentations and discussions. We'll now move on to questions. And I'll request the audience to put your questions on the chat box so that we can take it up. So the first question, some technical question for Rukmini. So is the CRS data available to everybody and how is it accessible? And there was also one question on death data can you discuss again about the death data and so on? Maybe you can start off this and then we can move on to other questions. You are still muted and I'm trying to unmute you. It's now done. It's not working. Is it working now? Can you speak?
That should be okay now.
Yeah.
Yes.
Yeah. Thanks. Sorry.
So just to sort of explain the CRS, which is the civil registration system is supposed to it's structured downwards from the Registrar General of India's office, and every state is responsible for the CRS at its own state level. in states, the level of decentralization and the nature of decentralization varies from state to state, but essentially in every state there is a central registrar, and then there are district level sub registrars and one level lower than that. In some cases it overlaps with the either the health machinery like the district hospital. In some cases it overlaps more closely with the administrative machinery like the district magistrate or the panchayat's director. um, I'd say until even 2000, I mean, even the 2019 data that now we have, which shows substantial improvement in the level of death registration in India is encouraging, because up till 2018 as well, while 86% might sound like a good level all India, it still means that in states like Bihar, just over a third of deaths were being registered. So just to reiterate, these are deaths from all causes. There is no medical, yeah, whether or not there was a medical certificate in this case. I would reiterate that not everyone registers a death anyway, and this is particularly the case in rural India. Um, so because after we started reporting this data, multiple people have asked why this data is confidential, why it's not being put out. So again, I want to explain my point about legacy issues and about changing the nature of, or at least the direction of democratic pressure as new challenges come up. So in the last data that we had for the civil registration, right until a week ago, was from 2018. So typically this data has been released with a 2-year lag. The government does its own work of cleaning it up and doing age-wise and gender-wise cross tabs and a bit of cause of death, all of that. So typically we would expect data from 2020 after 2 years, and we would not be expecting the second wave data for another 2 years. Two things have changed. One is, of course, the fact that we need this data now. The second thing is a lot of states have been able to go almost fully online with their civil registration system data. So this data is available, and now that we know it is, we should be putting pressure for it to be released. It has never been public this far, the updated sort of online system, and it isn't yet in any state. So it requires journalistic work to gain access through sources to the state level system. What a number of all reporters who got this data from any state are putting it together. Some of us have put it on GitHub, but it will be in a more structured manner soon. So it hasn't been made available by the state, but it will be made available by all the journalists who've reported on it. And just to, if the deaths excess mortality point wasn't clear, all that we've done is looked at CRS based all cause mortality for a particular period, compared it with the past normal, which would be for as far back as we know. In most cases, I only had data for 2018 and 19 as non-pandemic years, so I had to use that as an average. But in some other states, people have 5 years data and are able to compare that. So all that we're able to say through this is what the scale of excess mortality looks like for a particular time period. I hope I answer the question about whether more such data is coming. It relies on it depends on the enterprise of journalists. So a number of journalists are pursuing it, but it's not something anyone can be, there's no calendar for it. Pinaki,
Thanks, Rukmini.
another question,
Sure. Yeah, go ahead. Yes.
This question is actually about sero surveys, because I think there is during the pandemic there were a number of bodies that did not typically do quantitative work, who then did some of it to help answer pandemic questions. And this was the case for sero surveys as well. And some, these were of varying quality as well. So I wanted to ask you, Murad, about how you think through the process of using data like from sero surveys, because I remember in the case of Bihar, they didn't even, there wasn't even a paper or anything of the sort. You had to piece it together from news reports. So how do you work through that issue of how to use this data, whether to use it, that sort of thing, with organizations that don't typically do this work?
Thank you. Sorry, I won't mute myself again so that I can answer your questions. So in the case of Bihar, actually the serosurvey data itself was national serosurvey data. And one of the things is that national serosurvey data that occurs, there were 6 districts in Bihar covered in the national serosurvey. And one of the things which is a real shame and which is, I think could easily be changed is that mostly that district-wise data is actually not shared. However, it's clearly released to, presumably to state governments, and some of them are prepared to release it to the media, and so you might get snippets of it. So in that case, it was serosurvey data from a survey which was done carefully and by people who are presumably experienced at doing quantitative surveying. The methodology for the National Serosurvey was, I think, decent. On the other hand, a lot of the technical detail was not there. You just had the headline figures from each district. So, had some confidence in it, but it would have been great to have a little bit more detail. On the other hand, there have been other serosurveys which, where the data is, you have no idea about anything. You don't know about what antibody test was used. You don't know what sampling methodology was used. You don't even really know if there was proper randomized sampling, if there was correction for the demographic features of the population. So you're either forced to junk that data, and I hate to do that, or you just accept it, but with, in a sense, huge uncertainties on it. So you say, okay, I'm going to take this headline figure and I'm going to ask, is it roughly consistent with whatever other data we are getting from serosurveys, perhaps in other places? And is it believable or not? We'll talk about it, but we'll talk about it with a whole host of caveats. And as you know, talking about Indian COVID data, you often are forced to talk about data which you think is problematic, but adding in a whole lot of caveats about why it's problematic. So maybe I can also talk about, a little bit about this CRS data, about this civil registration data, because I've been looking at the raw data from quite a few of these recent reports, all-cause mortality data. And in that data, it's really striking that, it's complicated data in itself to interpret sometimes. So let me tell you one thing which you see very often. You very often see a major drop in mortality around the time national lockdown starts, so around April 2020. So prior to really COVID mortality kicking off, you'll see this drop. It's most remarkable in fact, in Assam. Out of all the data that I've looked at, it lasts 4 months, and Assam's baseline registered deaths go down quite dramatically. And anyway, baseline registration in Assam is relatively low. I think it's in the 60s, 60% some odd. And then it drops really, really low during this period. So clearly registration there was quite sensitive to national lockdown. And one question which you generally don't know the answer to is, when did it return to normal? When did people start to register deaths as normal again following a national lockdown? Sometimes it seems to bounce back up straight away after a month of very low registration. Sometimes it seems to take longer. So then you've got all these kind of longer term changes, trends in death registration going on, especially in some states where death registration is improving over time, or where digitization happens, systems move online, and that seems to lead to a spurt in death registrations. So I'm just saying this really for members of the audience who believe that extracting excess mortality data from death registration data is easy. The answer is it's not always easy. Sometimes you have to have some local knowledge about what's going on in that state with death registration over time, understand whether trends are actually trends in mortality or trends in registration, for example, when you're looking at kind of the past few years, and then kind of use that, factor that in when you're trying to compute excess mortality. Nevertheless, all of that said, so you end up with uncertain estimates, but you still end up with very, very striking estimates, especially when you're looking at this wave for the number of excess deaths that you've seen, as Rukmini has mentioned.
So one related question, so regarding, serosurveys and so on. So if you have reinfections, then how reliable are these serosurvey numbers and so on?
Well, I mean, serosurveys are serosurveys. They tell you how many people with that given assay, that given antibody test positive for antibodies at that moment in time. I think the issue is that, okay, yes, we know that the tests are very different. So some antibody tests might be more sensitive to older infections. So some tests lose sensitivity over time. That's one thing that we learned quite rapidly. In fact, they can lose sensitivity over time. We don't know exactly what are the correlates of protection. So we don't know to what extent being antibody positive, and in some cases, often it's not neutralizing antibodies, maybe it is in some, but to what extent that's protective, what extent that correlates with actually being vulnerable to reinfection or not. I think we have to just take them again with all of those uncertainties. So they tell us something, they tell us about prior exposure. They don't give us perfect information about that. Some antibody tests are likely to give us much better information about prior exposure than others. I think there's a learning process that the bodies doing these tests are tending to understand a little bit more about, why it might be important to maybe use better antibody tests, why it might be important to sometimes use maybe more than one method as a way of a kind of sanity check on the results. But yes, I don't think that we can be certain that just because somebody is antibody positive, they're not vulnerable to reinfection, or because they're antibody negative, they are vulnerable to reinfection. I don't think either of those is necessarily true.
Okay, one more question, and then I can shift to Rukmini. So given the limitations in data, what do you think about a good estimate for IFR, or how do you reliably estimate IFR? It's a difficult question.
That's a question for me.
Yeah.
Well, I think what you do is you just take the data that's available, where you have some way of putting some credible uncertainties on it. So putting some, actually quantifying the uncertainties, you put that on, and where you don't have that, you just construct you kind of create your point estimates, but with the kind of caveat that that there's a lot of uncertainty in those, and then you try to match those up. So say, let me take an example of Chennai. So in Chennai, you've got official reported COVID deaths, you've got some serosurveys. In fact, quite a few have occurred in the city. You have excess deaths data, so all-cause mortality data. And if you use the different surveys and you use either the official COVID mortality or the all-cause mortality, excess mortality, and that too can be calculated in different ways, you come up with a number of different IFR estimates. So I put out a short document on that. And you find that those estimates range from about 0.15% if you use official mortality and one of the later serosurveys, up to about 0.4% if you use all-cause mortality and one of the other serosurveys. So you get a wide range. I think it's important to have a kind of sense in your mind of what you believe from having looked at all of the different data that's coming in. And I would kind of honestly believe that the truth lies somewhere in between those kind of extreme estimates where you take official fatalities at the one end and where you take all-cause mortality at the other end, and where you have different serosurveys perhaps telling you slightly different things about levels of spread. So I would say, okay, I believe, and this is a belief which is still open to being questioned, that probably true IFR is perhaps around 0.25, 0.3 in Chennai. That would also match what I believe about Mumbai based on my examination of last year. So this is, for 2020. Now, I do believe that during 2021, those numbers have increased based on all the different bits and pieces that I've been looking at of all-cause mortality data from villages and so forth. So really, those are kind of early estimates based on 2020 data. And I think we will have to revise them as more of the current data comes through.
Thanks, Murad. Question for you, Rukmini, and this is related also to some discussions that we had with some journalists earlier. So this comes from Abhijit. So can we have local surveys? And we had some discussions with journalists, some other journalists, about how to organize these kind of local local surveys to get a sense of how many people have died in this community over this period. So is this viable? Are you thinking of doing something on these lines and so on?
I think it is viable. I'm not thinking of doing it, and I'm not a. I mean, it's great to talk to journalists, but I think there is a lot of existing knowledge about, in other groups of people that you could tap into for surveys like this. So, one good model that we have for India is the Million Death Survey that was done in 2013, I believe. There are other surveys that do not typically ask about deaths, but that can be potentially reoriented to ask about this. So yes, I do think small surveys would be useful and can be done quite easily. I mean, look at Jharkhand, what an excellent example. Murad has pointed this out as well, that poor state did a large door-to-door survey to estimate excess mortality within 10 days. That's immediately a model for other states to follow. And in a few days, there's another big state that is going to announce a door-to-door survey. So yes, I do think there will be good household surveys done on this. It's really not expensive, and there is a lot of institutional knowledge about how to do good household surveys.
Another question on availability of data, and this is something we have also confronted quite a bit. So the state bulletins that come up are very gross information. No, you have deaths and reported cases and so on. So as journalists, do you have better access to, like, example, gender or age-wise distribution of data? And is this something that one can, I mean, similar to what we were thinking about the GitHub platform to share the CRS data and so on, is this something that a project that one can work upon? Or is it, I mean, what kind of data do you have access to? Is it just the public data that we get, or is it something more that you can have access to?
Well, typically journalists who have had, and this, is really the wonderful role that local reporters across the country have played in telling these widely varying stories about the places that they are from, which have helped us form a whole of what is actually a very heterogeneous, not just country, but heterogeneous pandemic as well. But journalists will typically immediately use this information. So you would see this in news reporting. I think it'll be great to reach out to more journalists to build a place where everybody can put their data. Not everybody is comfortable even with Excel, let alone GitHub. I mean Excel, yes, but not GitHub me either. So there's a little more than is available in state bulletins that the journalists do get, but typically they would be writing about this, and it's out there.
Mm-hmm. So maybe as I pass through the questions, Murad, Rukmini, would you also like to talk about vaccination, about the spread of vaccination and its consequences on the mortality and so on?
Sure. I'm actually going to use my bully pulpit to again ask Murad a question.
Sure. Carry on.
Worked on this, or if you, so I don't know if you have the numbers, and I'm putting you in a spot, but given what we know about the second wave now, do you think that India's either IFR or CFR, though I don't even know, whether to even consider the CFR anymore, do you think India's IFR now is essentially not particularly different from most other countries, even the US or UK, for example? Where does that stand now?
I think that India's IFR now, I think India's IFR is where you expect it to be based on age structure. So you do have to take age structure into account, first of all. Obviously, India is a much younger country than the US or than European countries on the whole. Once you factor in age structure, I do think that even during the first wave, I think based on the excess deaths data that's coming out, India's IFR was roughly what you expected it to be based on age stratified IFR levels. You also have to bear in mind that sometimes you might have uneven spread. So you might have disease spreading in a younger population and less so in an older population, especially when you have housing segregation along lines of class, and then class also corresponds. You have different life expectancy, again, along lines of class. So disease might spread through a younger working class population and spare an older middle class population. In some cities, we saw that happening. So when you bear all of that in mind, I think IFR values that you were seeing during the first wave were very comparable to what you expect from international data. I also think that IFR values during the second wave are clearly higher than they were during the first wave. Well, I say clearly, we don't yet have decent seroprevalence data or other data to estimate spread, but are very likely higher. And just if you take the example of Madhya Pradesh or Andhra Pradesh, where you've seen a mortality of 0.2%, and then you have to ask, well, what fraction of the population got infected that 2 in every 1,000 died in a space of a few months? Even if you assume it was very, very high, if you assume that it was half of the population, then you still have an IFR of 0.4%, and that's quite high. That's higher than the kind of first wave estimates based on India's age structure. So I think that we will have to kind of rethink what fatality rates you expect in India. These village reports that we were looking at, where we looked at 61 reports, and in a typical village, this is in North Indian states, you found that about 3 in every 1,000 people died in a very short space of time when disease raged through the village. That was the median value. And that's a very high value, actually, 3 in every 1,000, because that's a kind of lower estimate for IFR as well. So IFR is very likely quite a bit more than that in rural India during this wave. I don't think we'll arrive at a very clear and credible estimate, but we'll arrive at a kind of feeling for what it likely is.
Okay. So Murad, would you like to say something about vaccination? So because since you have looked at data in Mumbai and you have tried to see how the impact of vaccination has been, so maybe you can share your thoughts on this, of how the numbers have been affected.
So I think it's a really important story. I feel awkward kind of saying my kind of thoughts on it because they're based on very incomplete data. Right. I mean, there's the right way to do things when you're trying to kind of quantify vaccine effectiveness. And what I'm talking about is looking for correlations between vaccinated groups and a drop in mortality. And when you looked in Mumbai, you started to see, as the elderly were being vaccinated, you started to see what appears like a drop in mortality relative to what was expected based on, number of cases or based on the level of spread in the city. You started to see what seemed like a drop in mortality, and that continued to manifest itself over the period of time that the elderly were the kind of, with some delay after it was the over 60s who were primarily being vaccinated in the city. And I know Rukmini has looked at a lot more data than I have from around the country, and that this same pattern seems to emerge in several places. You see the typical age of people who are dying from COVID tending to go down precisely a few weeks after you see relatively high vaccine coverage amongst the over 60s. Now, that's a correlation. We can't say that it's a causation. Hopefully it's a causation that, so I kind of put out there that I'm hoping to interpret this as a vaccine effect. But of course, the right way to measure whether something is a vaccine effect would be to do something like a case control study, as they're called, or cohort study, where you kind of match up vaccinated and unvaccinated populations, or you examine cases and you see how many of those cases are from vaccinated individuals and how many are from unvaccinated individuals. And if you understand vaccine coverage, you can infer something about vaccine effectiveness. So just looking for correlations is the most imperfect way of doing it. But I do believe that we saw a vaccine effect. I don't think it would have had an overall effect in reducing mortality. I mean, it would have reduced mortality overall, but I think that was masked by the fact that you had generally higher mortality during this wave. You had a generally more severe wave, which penetrated deeply into all areas of the country, and where you perhaps had more lethal variants in play as well. So that masked what would otherwise be a vaccine good news story, perhaps. I don't know, Rukmini, do you agree with that take?
Yeah, I agree, and a version of that is what we did see elsewhere as well. And then I think as vaccination picked up among younger people, all of that became a bit muddier. And then the combination of not entirely knowing how the new variant affected different groups of people muddied that further. So yeah, with the incomplete data that we have, a neat vaccine effect has become very hard to market.
Yeah, and there was also this discussion, and it even reached the Supreme Court. Basically, young people are dying during the second wave. Perhaps a mixture of the vaccination effect and also the number of deaths that are going down in the elderly population, and not the vaccination effect hasn't yet reached the younger population, and therefore the numbers going up. And so do you think that journalists can play a better role in telling the story better, so that when it reaches the Supreme Court and the Supreme Court makes such a observation, and it has its consequences on policy? So maybe you can share your thoughts on this also. But what do you think the role of a journalist is in this circumstance?
Well, broadly, I would say that a lot of journalists have played a heroic role over the last year or so at great personal risk. And I'm talking about frontline reporters who often work for very little money. I'm not talking about journalists like myself who, work largely from home and are couched in a lot of privilege. So all, virtually all that we know about the way the pandemic has gone across the country has been thanks to reporters. There's been a lot of investigative reporting, even though the costs for that are high. Of course, there has been some trouble with reporting scientific and scientific information, medical information. Um, yeah, I mean, there is there is a sort of worst end of it, but then the middle issue of the sort that you are describing, of not being able to say very clearly if what we're seeing are more deaths among the people or whether it's the proportion that has changed. Sure, I think more access to experts who can put things in perspective would help, and not everybody has that access, not everybody has the time. So um, sure, that could get better, but overall I feel I feel very good about what Indian journalism has done in the last year. So that's the side I
Right.
got.
Yes, I would like to kind of just continue Rukmini's point about the role that journalists are playing, because I feel that also there have been changes. So I think there have been some journalists doing fantastic work right from early on, but then as this second wave has grown, I think you've also seen a change. You've seen a higher volume of on-the-ground reporting, really telling stories from villages, telling stories from amongst marginalized communities, which you perhaps didn't see in the same way during the first wave. And it's like an extremely valuable resource because all the numbers and all the data that come out, you need to contextualize it. So you need to understand how is it possible, and it's only possible to understand how those numbers are possible if you start looking at what the reporters are telling you about what's actually happening in villages. Well, how does an epidemic play out in a village? How fast does it spread? Who is affected? How many people get care? And how many people ultimately die? So that kind of crucial ground level reporting is, I think, a key source of understanding during this wave, especially.
Thanks, Murad. One question from Rajguru. So do you think underreporting in some way misled or led to complacency in the context of addressing the Indian second wave, that people really didn't realize the numbers ground and therefore people were not ready with the infrastructure to to confront the second wave?
In a word, yes. I think that there was a connection between underreporting and complacency. I think that if we'd had a kind of general atmosphere of data transparency and general honesty, we would have just been able to say, we wouldn't necessarily have been able to predict how the second wave would play out in all of its detail, but we would have at least had a better sense of the level of danger. So we would have had a better understanding of what are the dangers. We would have also had an understanding of what are the vulnerabilities if we'd had better data, to what extent is rural India, has it been spared so far? And is it really vulnerable to another wave? Or is it that actually the disease has raged through already and we've had relatively few fatalities? And we really didn't know the answer to those kind of questions because we had such poor data around the levels of spread and also around fatalities. I don't know, Rukmini, if you agree with that.
I do. But there were, yes, I do agree. And I would not want administrations that didn't ramp up capacity to the extent that they could to be able to say that, by not knowing the real numbers, that's why they didn't ramp up as well. I wouldn't like them to get that way out, and particularly because to most people working on the ground, doctors, for instance, a lot of this was only something that data confirmed post facto, and they felt that they were seeing this already. So, and the other thing, and this is really a question I have, and I've talked to Gautam about this, I've talked to Murad about this, which is that I'm not sure. I'm not sure if people in their behavior, so I'm not really sure about how to think about people's behavior. And I know that that is in a way something you do need to think about in modeling, or when you think about the pandemic. So when people say things like, oh, people got complacent and stopped wearing masks, and that's why now, I just don't, it doesn't make sense to me that relationships, that numbers work that way. It's possible that people ran out of money or ration and felt that they had to go back. That makes sense. So whether, again, if people want to say that the numbers seem like underestimates and hence people became more cavalier, I just have not seen that sort of relationship between numbers and behavior and numbers at all.
So I think there are kind of these interesting, reports sometimes that you get from villages, for example, where you kind of really have this huge spectrum where at one end of the spectrum you have actually a belief that COVID is not real. It's prior to this wave, by the way, I'm talking about, reporters going to these villages and people saying Corona is a conspiracy. So there's that at one level. And then at another level, you have reports from villages where the villagers have literally kept people out. They've put a barrier in the way so no one can come and go because they are so scared of an epidemic, because somehow the information is reaching them that is raging through neighboring villages. So in that kind of local sense, it feels like what your sense of danger is, what your sense of risk is, seems to span the full spectrum from COVID not being real to being kind of terrified of it. And I just feel that if people had access to the kind of honest truth all throughout of, these are the dangers, that doesn't mean that everything is a moment for panic, but this is dangerous disease, this is what's likely to happen. I feel that people would have been empowered to be able to make those kind of decisions at local level about what do we do to try to stop it. And I'm talking about people being empowered. Obviously, I would like to say the state would be playing this role of kind of, protecting people. But in reality, we know that in many cases, it's people themselves who would be able to protect themselves, or who would be protecting themselves. But they would have better information on which to do that, I feel.
One question from Chris Leffler. So he says that they have done studies on 11 states, and their estimate for fatalities is about 2.2 to 2.6 million. So is this plausible? What is your sense of, since let's talk about numbers. So what do you think is a possible estimate of mortality at this point of time? So what is the scale of underreporting that you have in mind?
I think it's possible. I'm not going to rule that out. And I think it's quite possible, especially when you start to look at, just when you have 2 months worth of excess mortality in Madhya Pradesh, and you see that that's 1.7 lakh deaths, so 170,000 deaths, excess deaths in 2 months. And then you say, okay, that's a state of about 85 million. If you've had this kind of level of excess mortality, what would that add up to? I think you can easily see how the numbers can go into millions. I haven't read Chris's study, but I'm perfectly prepared to believe that that's possible. I think we'll be able to be more quantitative. I'm being very cautious here, because as the data comes in, and it is coming in, that's the great thing, we'll be able to be more and more confident about what the level of mortality has been. And at some point, I feel we will actually be able to say with some certainty, yes, second wave mortality has been this much across the country. Right now, we're not quite there yet, is my feeling.
Sure. So one question from Nick S. So the question is basically, anything you feel scientists in academia can do to support and extract information while journalists are doing this exercise of getting access to data. So maybe Rukmini, you can share your thoughts on this. So as a journalist, what would you expect the scientific community to help you in sort of analyzing the data and so on? And what can be this back and forth?
So I think this a community has already built, and that's great. And I reach out to experts all the time. I'm a data journalist without significant data abilities myself, and so I feel like what I try to do is understand context and access data, and then usually seek expertise to make sense of the data. I feel very grateful to the community that's developed already. And I think this sort of cross-disciplinary thing has been great, because if otherwise there's sort of a typical list of people and epidemiologists who you feel you need to reach out to at all times, and they might not all be accessible, all be helpful, all even be thinking and working fast on this at the moment. I would imagine more outreach to journalists not writing in English would be very helpful. So in other states, if there are groups that can form that just in some way put out their information. Uh, After I started writing these excess mortality numbers, there's a number of journalists from other states who got in touch. And yeah, I just felt like they should also have more access to experts they could speak to. In terms of even extracting data, which is something that many journalists do have the expertise now for it, and newsrooms would often have someone, though I don't personally. That is also an interesting community that's developed of sort of public spirited developers, programmers who don't necessarily work in any of these fields, but are passionate about sometimes even their individual city or their hometown. So there's nothing that I personally seek in this space, but I would like it to be more broad-based for more people to have access to it.
Thanks. Murad, do you want to also share your thoughts, since you have been practicing looking at data? If you need more hands, more people.
Yes, and I think that interaction between scientists and journalists is like a crucial one. It's really it's been central to whatever light we do have on the pandemic. It's come through those kind of interactions, because people like myself, we don't really have a clue about where to go to get data, and what are the kind of underlying contextual issues. In some cases, at least, I don't understand what are the underlying contextual issues around death registration, around trends in mortality, partly because I'm not a demographer, but also partly because I haven't been into government office and registered a death. So I need to talk to people who understand what it looks like on the ground, what the delays might be, what are the kind of barriers that might be put in the way of somebody trying to do that. And I think it's out of that so it's not just a one-way interaction that the journalists need to speak to scientists in order to get a handle on the data. It's also another way that the scientists need to actually talk to the journalists to know whether these numbers are what they mean. Sometimes, I have this thing like in Bombay, which I follow, Mumbai, I follow very closely. And sometimes I see something in the data and I don't know what it means. And I found that talking to journalists sometimes actually gives me an idea of what it might mean, where it actually might come from. So it's a very crucial interaction, really.
So I think we are about to end. Gautam, do you have any final thoughts or questions to ask? And then maybe also you can say some concluding words.
No, I had a specific question, and that's about, we've been thinking a lot about IFR, and IFR is a sort of delicate object. I mean, it depends a lot on whether people have access to medical facilities. And people, for example, as we saw in Delhi, I mean, the television cameras were concentrated on Delhi, but certainly this probably happened all over the country, that people died because they just didn't get medical attention in time. And so that would have shifted the numbers up. I'm just sort of wondering to what extent there is a balance between people who died who should not have died because they just didn't get medical attention, and people who died directly as a consequence of the fact that the disease has a certain IFR, in both the first wave and the second wave. I wondered if you had any thoughts about that.
I think that's a crucial question. And I think it's going to be one which, it'll take some work to try to unpack the scale of avoidable deaths. I think one way that we might get some insight into that is where we see either a city or some region which has managed this second wave a little bit better, which was a bit better prepared, which managed to have a decent oxygen supply where beds didn't run out. And if we are able to get IFR estimates from places like that, and then we try to compare them from maybe regions at the opposite end of the spectrum, we might get some sense of what is the possible scale of avoidable deaths which have occurred during this wave. Because I think we need to understand that, if at least partly because of accountability. We need to know with proper planning to what extent could the scale of mortality have been mitigated. I have strong feelings that actually I think in many, many ways this wave could have been mitigated with some planning and forethought, and this is just one of them. there was also of course, the issue of high mobility around the time when the data was clearly saying that you've got a lot of active infection around, and at the same time you had high mobility because of elections, because of religious rallies. So there was another aspect of avoidability in the whole thing. And then there's this aspect of avoidability because of the lack of medical care and the lack of planning around oxygen supplies and so forth as well.
Rukmini, do you have a...
Yeah, I was wondering also if, I also would be interested in knowing how this can be worked out. And two other, as Murad said, comparing cities that managed it better could be one way. The other thing I've been thinking is whether tracking IFR in a region over time, especially when numbers started surging, will say something about what we know about how that city or region could manage it when the numbers were smaller, and what it meant, if there's a big proportionate, there's a increase that's greater than it should be in proportion when the numbers start rising fast. I also wonder if we were able to get better gender disaggregated and age-wise data, if that could tell us something as well. If we see, there's a much higher than expected share of deaths among younger people, that's not explainable by the variant or by vaccination effects, then perhaps that could tell us something as well. And I completely agree that intuitively and anecdotally certainly seems to be a huge part of what happened.
Just a sort of follow-up question on that. Sorry, Pinaki.
Yeah, carry on.
In the sort of data that some states have shared sort of, privately, there's this huge mismatch between deaths in women and deaths in men, sometimes a factor of about 2 to 3. And again, there seems to be no reason from what we know. We do know that women are a little less likely to die of COVID-19 than men, but typically that should be in the 40 to 60 or 48 to 52 range. But here we're seeing a much larger gap. Are you noticing this in what you've been studying, this gap for women and men specifically, that women's deaths are being underreported at a much larger level than men?
So I have to say I've only had access to all-cause mortality data, which is not disaggregated by gender, I'm afraid. So I haven't seen that, the gender breakdown in the all-cause mortality data. I don't know. Are you talking about all-cause data, or are you talking about official recorded deaths?
Official recorded deaths of COVID-19.
Official recorded deaths of COVID. Well, I don't know the answer, but I would just say that I think we need to assume that all different kinds of marginalization increase your risk of your death not being recorded, because anything which reduces your likelihood of having access to testing, access to hospital care, access to the medical system in general, and gender is obviously an important factor there as well, is going to reduce the likelihood of a death being recorded as a COVID death. So while I don't know the data, it wouldn't massively surprise me if gender was another aspect along another of the fault lines along which the likelihood of a COVID death being recorded was playing out. But that's a very vague answer. I don't know if Rukmini can say something more specific.
No, so I can't say something more specific, but I just have a couple of small data points that have come up that would perhaps be useful to think about. I too don't know if this is the explanation for it. One is something that came up very early, and unfortunately we've had no subsequent data on it. When the ICMR first put out its analysis of the first 1 million tests that it did in the IJMR at the time, women were slightly more likely to test positive than they were to be tested in the numbers. And that is something that had not, we know historically again from NSSO data that women are less likely to access health than men, even in circumstances when they are more ill. There was a study done in the OPD of AIMS, for example, and I think women made up, even discounting obstetrics and gynecology, women made up, I think maybe a third of all OPD visits. So there's that to start with. Then vaccination. We've already seen a big divergence in, a small divergence, but a building divergence in vaccination rates between men and women. So that's something to worry about. I wouldn't say that it's necessarily contributed to this. And then the other thing that showed up a couple of times, but then I haven't looked at it systematically enough to know if it followed through, which is that in the early sero surveys in Mumbai and Ahmedabad and Delhi, and then I don't know if that applied subsequently in Delhi, the seroprevalence among women was actually higher than it was among men, which is very different from what testing and case data was showing at the time. So I don't know if that, perhaps they were more asymptomatic cases, but then what that meant for later complications, which we now know can occur in asymptomatic people as well. I think all of that, those are potentially areas that I might look at.
I think it suggests also that we do need to have all-cause mortality data also broken down by gender, because then we can see whether there's a mismatch between what you're seeing in mortality data and then what you're seeing in the official fatalities. Of course, bearing in mind that you might have a mismatch in registration as well, that especially in states where death registration is weak, it might be gender skewed as well. So, it's all complicated, but yes, we should look for that at least.
Yes, I'll just quickly add that yes, the CRS does show that women are less likely to get to have their deaths registered, even compared to their share in the population. And I hope to have something on gender-wise all-cause mortality soon.
So now we've come to the end of this session. Let me thank both Rukmini and Murad for a wonderful conversation. There's been a huge amount of interest. I think there are more questions that we've not been able to address. And I think you've really pointed out to us the really important questions that lie, the fact that we do, as Indians, need better access to the data that our government collects. Our taxes pay for data. It's not just data of the top that you've been talking about, but even ICMR's testing data, the sort of clinical data that is collected by NCDC, all of the data, the information that is there and potentially valuable to us to decide what are the important decisions that we need to take going forward. What can we do if there is a third wave? What can we do to cope better with it? So thanks again for a wonderful discussion, and very grateful to you.
Thank you.
Thanks, Sumit.
Thank you all. Thank you very much.
Yeah, thanks to all of you for joining.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Bye-bye. We will end the meeting now.